executives. My name is Esty Garrity, and I'm Esri's Chief Medical Officer and Health Solutions Director. I'd like to thank you very much for the honor of speaking with you today. I only wish it could be in person. Believe me, I love Jamaica. Oh well, we're still going to have some fun with this. Today, I'm going to show you why health is so spatial, starting with a brief history, and then giving you a sense of what a modern GIS platform can do in the service of fulfilling the spectrum of health missions from social services and public health to healthcare. So let's get started. The earliest mention I've found of an association between health and place was with the father of medicine himself, Hippocrates. In his treatise on airs, waters, and places, he wrote, "When a race lives in a rough, mountainous country at high elevation and well watered, where great differences of climate accompany the various seasons, there the people will be of large physique, well accustomed to hardihood and bravery, with no small degree of fierceness and wildness in their character." On the other hand, he said, in low-lying, stifling lands, full of meadows, getting a larger share of warm than cold winds, and where the water is warm, the people will be neither large nor slight, but rather broad in build and fleshy. Bravery and hardihood are not an integral part of their natural characters. Very interesting stuff. He also wrote about different characteristics of cities and how they influence health. He was incredibly insightful. Well, now I'll move forward in history about 1,500 years to tell you about the great Persian physician Al-Razi. He was truly a Renaissance man, despite actually living during the Middle Ages. Besides writing an actual encyclopedia covering many different topics, he was also a great spatial thinker. Al-Razi was tasked with finding the best location for a hospital in Baghdad. He is said to have walked the city, hanging slabs of meat in different areas. He monitored the slabs over time and found that one putrefied more slowly than all the others. He hypothesized that that was the place with the cleanest and healthiest air, and so that's where the hospital was built. Clever guy. Now, one of the most fearful diseases of all time became the subject of the first known health map in 1694. Nobody knew what caused the plague or sustained its spread, but people did know that sometimes it could be contained. In this map, you're seeing the province of Bari in what was then the Kingdom of Naples in Italy. The author, Filippo Arietta, was royal auditor for the province under the military governor. There's a lot to see in this map. First, there are 3 levels of containment designed to prevent the spread of plague. There was a coastal patrol to contain active disease, and a dark wall separating off that active area. On top of the wall are tents symbolizing troops to enforce the quarantine. The third containment level was the General Provincial Cordon, also monitored by troops. This was a major military operation. Towns and cities were represented using simple drawings of either a church with a cross or a hospital without the cross. Trees were meant to show uninhabited areas. And now we've come to the point in history that I suspect many of you know well. This story begins in 1849 when 54 of London's poorest citizens wrote a letter to the London Times. "We live in muck and filth. We ain't got no privies, no dustbins, no water supplies, no drains, and no drain or sewer in the whole place. We all of us suffer, and numbers are ill. And if the cholera comes, Lord help us." Unfortunately, in just a few years, cholera did return to London, and the people were terrified. It was said that a person could wake up feeling fine and be dead by sundown. The symptoms were upset stomach, vomiting, gut cramps, diarrhea, and a racking thirst. And near the intersection of Cambridge and Broad Streets, more than 500 people died in little more than a week. That's a lot of friends and neighbors. Now, this is where the hero of the story comes in, Dr. John Snow, who for his contribution was later dubbed the father of modern epidemiology. Well, Dr. Snow didn't know any better than anyone else what caused cholera, but he took a different approach. He made a map. What you're seeing is a map of the Soho district in London. Black bars represent deaths from cholera. Dr. Snow also mapped the water pumps in the area. You can easily see that one pump had a lot more death around it than the others. Dr. Snow notified officials, and the handle was removed from the suspect water pump. That intervention ended the cholera epidemic that year. At this point, I hope I've convinced you that the relevance of place to health is not a new concept. However, technology has certainly advanced tremendously so that we can do so much more than Hippocrates or John Snow would have ever dreamed possible. But before I show you some of what is possible, I want to provide a framework for how we think about GIS in health. I believe we should be thinking in terms of workflows. Now, a workflow is an organized and repeatable pattern of business activity that's been logically ordered into processes that get things done. Those things that need to get done might be transforming raw materials into products, or it could be providing services or processing information for various purposes. The workflow accounts for all of the people, competencies, and resources, both material and financial, that are needed to accomplish the task at hand. Let me give you an example of a very simple health workflow. Okay, a man with a fever comes into an emergency department. He's registered and roomed, and then is triaged or interviewed by a nurse who collects all sorts of information, including the man's travel history. That information is entered directly into an electronic health record. The patient is then seen by a physician who reviews the electronic record and any laboratory tests that have been done, and ultimately decides to discharge the man to his home with treatment recommendations. But even a simple workflow can cause problems when a system's under stress or the workflow is flawed. This is what happened in Dallas, Texas, when Thomas Eric Duncan presented to the emergency department after returning from travel in Liberia in September of 2015. Although the nurse collected that critical travel information, the data did not appear in the physician's standard workflow, so the physician had no compelling reason to keep the patient in the hospital. 3 days after Mr. Duncan was discharged, he was returned to the hospital, placed in an isolation unit with a diagnosis of Ebola virus. This flawed workflow, where essential information was not seen by the attending physician, could have led to several individuals being exposed to the deadly virus unnecessarily. My point in telling you this story is that workflows need to be very intentional, well thought out, tested, evaluated, and revised. It's an iterative process. We've started that process for you as you think about applying GIS to your health challenges. Just about every workflow will begin with data. You may already have data, or perhaps you'll perform fieldwork using mobile GIS tools to collect data. From your data, you can then visually describe your community. You'll be able to characterize the social and economic environment in which people live and show the geographic burden of disease. Then you'll want to perform analysis so that you can find health inequities or gaps in access to care and identify the root causes of these problems. Then it's time to mobilize your resources in a geographically targeted way. This will help you use your resources wisely where they're needed most. Outreach and communication are critically important functions to ensure transparency, provide risk communication, or engage your community partners. And we all need to be mindful of outcomes and how our work impacts those outcomes. We can measure impact geographically, look at before and after interventions, or compare our actual results against our goals for an area. I would encourage you to think about how GIS can help you in all of these areas of your workflows. Let me show you how it can be applied to a few different problems. Let's start with homelessness. This is a huge concern in the US, and I read recently that there's been a big jump in the number of homeless persons across Jamaica in the last 3 to 4 years, particularly in Kingston and St. Andrew. We may want to start with identifying where homeless people are located in our communities. In fact, this is an annual requirement in the US. This can be done using a mobile app to get current information on the homeless, information that will help provide the right resources to the right people in the right places. We can display the data as a heat map, which is shareable with the community since exact locations of homeless people are not divulged, but the extent of the problem is very clear. The next step includes bringing in additional data sources to help us understand the risk factors associated with homelessness. In this case, we're showing unemployment rates, people living below the poverty level, families without health insurance, and places with a lack of affordable housing. We can use those risk factors to do some analysis and create an index of risk. We found several communities at high risk for homelessness, shown here in pink. This helps us to be more strategic in deploying our limited resources to areas where they're needed most. The next step in our workflow is all about action. We can put all of our relevant programs, community partners, and resources on the map. We can also make this information accessible in a mobile app so users can find the nearest resource to their current location. And we can use dashboards in a number of ways. Let me zoom in on this one. Here, we're tracking our people who are in the field, currently surveying homeless individuals, to get a total count. Now, from the blue dots, they're going to show up every time a field worker submits a survey. We can interact with our collected information right away, like in this case, where I had just clicked on the pie chart to find the locations of homeless people under 18 years of age. This is a group that I want to get resources to immediately. The dashboards also help me track against my goals. Here, we're seeing the average unemployment rate for the entire county, which is almost 10%. And I can compare that to the national average or threshold amount of 4.7%. Our goal in this scenario is to get every one of our communities below that national average. When I select a specific community, the panel on the bottom left quickly shows me that this community has exceeded the target. I'm also presented with a pop-up that includes a narrative about how this community is performing on all of those homeless risk factors and even includes some helpful charts. All this information helps me understand each community and determine if any of our intervention efforts are making a difference. A big part of the intervention strategy in this particular scenario is proactive outreach and education in at-risk communities. This public story map helps explain to stakeholders the factors that we studied to identify the target communities, the location of homeless in each community, and details on available resources for this problem. I hope you can see how this kind of approach is applicable to all kinds of population health challenges, from working with your vulnerable populations to improving access to care and connecting communities with available resources. Now let's apply it to another major health concern, vector-borne diseases. I know there is particular concern around Zika, chikungunya, and dengue, all carried by the Aedes mosquitoes. The workflow that I'm going to show you could actually be adapted to any kind of vector, not just mosquitoes. Well, as you know, vector-borne disease refers to the fact that a number of animals and insects carry pathogens that can cause human disease. In fact, more than 17% of all infectious diseases occur this way. This causes over 1 million deaths each year. Billions of people are at risk for disease, and hundreds of millions actually become ill. Many of these diseases attack vulnerable populations, like young children, disproportionately. And the thing of it is, a lot of this suffering and death is preventable. Vector-borne disease is inherently a geographic problem. Geography plays a role in all components of an integrated mosquito management system, from prevention to surveillance to actually dealing with those darn vectors. In the next few minutes, I'll show you how we've configured GIS tools to support outreach and education, public requests, prediction and modeling of disease, treatment planning, organizing a workforce, performing interventions, and monitoring job status. Well, disease prevention begins with education. Everyone can play a part in reducing the number of common vectors like mosquitoes if only they have the right information at the right place and at the right time. To facilitate public outreach and communication, we've configured a story map template that helps an organization easily share its key messages with the public. A story map is an interactive tool that allows the integration of multimedia components. Here on the left, you see a narrative and a photo about the organization and its mission. And then they also integrated the appropriate page from their website. After all, why reinvent the wheel when you already have important data you can share? They may also choose to provide data from additional authoritative sources, like the U.S. Centers for Disease Control and Prevention in this case. The story map is always up to date because the link to the website is dynamic. So when the CDC updates their data, the story map is automatically updated. Of course, story maps are best at mapping. Here, the agency can provide data showing the extent of the problem in their community. The shaded polygon areas show human cases of disease, and the heat map shows where mosquitoes tested positive for disease. Users can interact with the map to zoom in and see what's happened where, and they can even use the animation pane to determine when things happened. The organization can also communicate to the public the steps they've taken to respond to customer requests, like you see in the blue dots, and to apply treatments, which are shown in purple. But no matter how much prevention individuals do, we still need surveillance activities, like analyzing data on climatic factors that influence vector abundance, monitoring virus activity, and incorporating citizen observations. This map of Aedes mosquito habitat suitability was created with our predictive analysis tool. It uses Boolean logic to analyze several layers of data. Here, I used freely available worldwide data on precipitation, temperature, elevation, land cover, and population. I simply fed in rules on parameters for each variable, like temperature ranges, and I get results that predict where this mosquito could be present year-round, in red, or as a seasonal threat, in yellow. As new or highly localized data becomes available, the predictions can be quickly updated. While predictive modeling to understand mosquito habitats is helpful, we also need to engage the population in monitoring. We can pull in tagged social media feeds. In this case, we see a Twitter notification about standing water on the highway. We also support YouTube, webcams, Instagram, and Flickr. Like this Flickr report noting that there were so many mosquitoes at the field, we could not fly there. This is important information for the Vector Control Agency, who might not otherwise have known about it. Our configuration also includes a dedicated citizen problem reporter. This app works on any mobile device. When you log in, either as a guest or using your social media credentials, you can see what kinds of things others have reported in your area. Here, there are some reports of standing water. Now, you could comment on the existing reports, but in this case, you decide to submit your own report of mosquitoes in the neighborhood. You enter the relevant information, which can be done as free text or using the selectable menu items, and even taking a picture. The device will use your location to put this report on the map. Once you've made your report, you can submit it so that the Vector Control Agency will see it right away. While it's great to have many methods of surveillance being conducted at any one time, it's critical to ensure that the data is available in a single common operating picture. That's why we've included this surveillance dashboard showing the real-time information about the number and species of mosquitoes that are collected and where they were collected, the virus types ascertained by the lab, and the human case data. This dashboard has 3 panels with additional data that together provide all of the inputs needed to plan vector control activities for this community. So let's talk about control. Location is a natural part of the workflow when responders plan their activities and field workers perform them. Any kind of field operation requires clear targets. This part of our workflow takes all of that surveillance data and uses it to guide operational decision making. I'll take you through the process. Let's start with planning. On this map, we'll focus on the 2 dots in the lower central portion of the map. These dots represent 2 reports that we received from that citizen crowdsourcing app I just showed you. There's actually a lot of data on this map, but let me particularly point out that yellow area in the top right. This is a school, and it's been highlighted as an exclusion zone. In other words, we want to ensure that field workers don't apply treatments near the school zone during regular hours. Sometimes, a different view provides more insight. Here we show aerial imagery, and on the right you can see that the planner can select any of 12 different styles of base maps to get exactly the view they want. Okay, now back to our 2 customer requests. One was for standing water, and the other was the mosquito report we made through the app. The planner can draw a treatment zone that includes the 2 points and decides that the best treatment will be adulticiding with a truck-mounted sprayer, and they assign a due date for this work. Notably, when the treatment box is drawn, the planner will get an acreage calculation that's going to help them determine how much chemical they'll need for this job. Let's see what happens next. I need to assign this work. I can view my available workers and their assignments. I choose to create a new assignment based on the complaints we received. We input the needed information, including the organization's own identification system for tracking their work. The assignment is now created. Notably, I can filter and view all of the assignments by their status, due dates, and priority. If we look at the phone, the assignment is sent there, directly to the right worker, and they can view all of the relevant information as they start their assignment. They can navigate to the job site. Once there, they can start collecting information related to their work. They first take a sample of the standing water, looking for mosquito larvae, and they complete their adulticiding treatment. All of the work is recorded, including the acreage treated and the chemical used, which is helpful for the required reporting that they're going to need to send. They send the update of their completed assignment, and the entire system is able to see that update. Again, we can employ a dashboard. This time, it's to review the open assignments by field staff and the status of those assignments. This solution, again, took the workflow-based approach from prevention to surveillance to control. Now, in my last few minutes, let's move from infectious diseases to chronic disease, and from population health perspectives to the hospital perspective. There are a number of ways in which a location-based approach can improve quality and patient satisfaction while also reducing costs. Let me give you an example based on the readmissions problem. Readmissions are defined as patients returning to the hospital within 30 days of their discharge for the same diagnosis. This is costly for hospitals and insurers, and in many cases is preventable. It's important to understand the root causes of the problem if we're going to find a solution. It may be that some people don't have the money for health care or have not been connected to the social services for which they may be eligible. Or perhaps people don't have health insurance and thus no primary care doctor to see to their chronic condition needs. And sometimes, even when people are connected and have insurance, they may simply be unable to get to appointments because of transportation or other geographic issues. I'm going to tell you how the Camden Coalition approached the readmissions problem. Dr. Atul Gawande even wrote about their achievement in an article called The Hotspotters for the New Yorker magazine. Basically, the Camden Coalition decided that rather than analyzing readmitted patients by their disease type, which had been the common method, they would try something new. They looked at their most complex patients, regardless of the disease type, and they grouped them. Then they performed a geographic or spatial analysis method called hotspotting on this complex group. They found that many of the readmitted patients lived in just a few of the area's low-income housing complexes. What they did was set up small primary care practices right in those buildings. This improved residents' access to primary and preventive care doctors who could help them manage their chronic conditions. But residents could also get help with their more acute problems, like head colds and earaches that saved unnecessary visits to the emergency room. By doing this, the Camden Coalition clearly improved the quality of care while also reducing costs by an average of more than 50%. Pretty remarkable, don't you think? Well, I know I'm about out of time. It goes by very quickly. There are just so many great ways to use GIS to help tackle some of your toughest problems and make your workflows more efficient, more effective, and more capable of adapting to your organization's changing needs. Thank you for taking the time to listen. Let me leave you with this slide showing you how you can stay connected with the things that Esri Health and Human Services is doing. We have a newsletter that comes out a few times per year. We're very active on Twitter, LinkedIn, and you can even find us on Facebook and Instagram. Our homepage is regularly updated with new insights, user stories, and demonstrations of our capabilities. And I hope you'll consider me as a resource as well. I'd love to keep in touch with you and assist with applying GIS to your work, because I'm a firm believer that health is very spatial.